All right, thank you so much for joining the TriNetX Summer Boot Camp 2025. I'm Daniel Novak, Director of Student Scholarly Activities at the UCR School of Medicine. And this is our penultimate week here. We're in week 5. We're looking at the Cox proportional hazards models and treatment pathways. This session is going to be a little shorter because it's not as there's not as much detail as some of the other ones, but what you've learned in all of the past outcomes analysis and propensity score matching components, some of that's going to be really valuable here as well because the interface is largely the same. We're also going to talk about why and how you might use some of these components in your studies, and what they can do for you as well, because these tools are already part of the TriNetX set. As always, I'm here to help you out. You can come see me anytime or send me an email if you need anything. And I'm happy to work with you on your projects, especially at UCR School of Medicine. Again, no funding or formal support from TriNetX. Some of my salary time from this was paid for funds with the U54 grant between us and City of Hope, but there's no actual additional conflicts or anything like that. Just to check in where we are, we're at our Bootcamp weekly overview we're at week 5 of 6. Next week, we're going to talk about posters, manuscripts, and writing tools. We're going to talk a lot more about AI than in past sessions. I think that's going to be something really valuable for folks, how to use AI and leverage some of the AI tools out there to really help you out. And I think also to look at some of the AI, specifically what ChatGPT is good for, what Perplexity is good for, what DeepSeek is good for, and to use those effectively to help you plan and develop your studies. And each of them has different strengths and weaknesses. So if you're doing the even more rapid process, examine your outcomes and check with an expert. That would be a good time to be doing that. And this is an expansion of last week's discussion of outcomes. We're moving from the propensity score matching and comparing cohorts. We are now generating initial outcomes, rebuilding cohorts still in our rapid process, and we'll show you how this can help do that. So really quickly today, using the Cox proportional hazards model in TriNetX. If you're familiar with Cox proportional hazards models and hazard ratios and hazard rates in other platforms and other ways of computing and using the CPHM in different statistical platforms, TriNetX puts a little bit of a spin on it in a way that's actually quite useful if you know how to leverage it. So let's talk about a particular use case for this one. So this is something that comes from some of my real life experience on this, but basically we have the issue of postpartum preeclampsia. So preeclampsia and eclampsia is most common to occur in antepartum women, but it can occur as late as 2 weeks or even out to several months beyond delivery of the baby. And recent research indicates that elevated risk for up to 6 months to even a year following delivery is something that needs to be monitored. So there can be spikes in blood pressure, protein in urine as a result of different kinds of main organ damage, and all sorts of important signs to look for when this is occurring. But because of relatively low surveillance rates after delivery, it can be really dangerous. That is, most of the time people are out of the woods, but that's not always the case. And it also disproportionately impacts Black women postpartum as well. There's really limited research on postpartum preeclampsia and on the predictive factors. Some research does exist, but it's enough to indicate a need for a more comprehensive study for people to really dig into this and understand the causal mechanisms and the predictive factors. No comprehensive list of factors exists at the moment, and it's really difficult to analyze prospectively because you don't always know, because of this exact issue, we don't know prospectively who's going to wind up getting the condition and who's going to need additional help. This can also be an emergency condition, right? A spike in blood pressure, a number of issues can arise really quickly and require a lot of emergency care. So this is a great opportunity. Looking at postpartum preeclampsia is a great opportunity to investigate using TriNetX. But how would we do that? There's not an easy way to immediately identify what some of the risk factors are unless we individually, using the tools that we looked at last time, we basically have to create lots of little cohorts that differ just by 1 or 2 characteristics, and it would get very complex very quickly. So we have to use a different tool to achieve our goals on this one. But fortunately, the TriNetX people last year, in around September of 2024, released a new tool called the Cox Proportional Hazards Model. Obviously, that tool's existed statistically for decades, but released it as a new tool within TriNetX. So really quickly, a Cox Proportional Hazards Model talks about a hazards rate. That's the probability an event occurring at a specific time or by a specific time, given that the event has not already occurred. So that's a hazard rate. And you'll remember this from your Kaplan-Meier analysis, which gives you a hazard ratio or hazard rate as part of your analysis. It tells you how likely somebody is over time to develop that, where your two components are risk and time. So the Cox Proportional Hazards Model estimates the impact of any one of a number of chosen variants on the hazard rate of an outcome. So it'll tell you, you can load in an unlimited number, and we'll talk about this in a moment, of individual factors, covariates, into this model and see how predictive each one is, or how much of an impact each one makes on that final outcome. So whether, what income race or what outcome, a rate of increased risk race causes for the particular outcome you're looking for, how many times more likely in that time frame you are to develop that. And this is actually particularly useful because the particular problem we're looking at here is time bound, right? We're looking at up to a year, right? That year, beyond that year, there's too many intervening factors that could complicate the analysis. But that 1 year time frame is our time frame that we're going to be looking at risk within. And with the Cox Proportional Hazards Model can tell us how much of that impact that we're looking to see. So that's really valuable. As I said, when you're doing your Kaplan-Meier analysis, you already get for each of your outcomes, if you select that box in your compare outcomes function that we looked at last week, you would already get a hazard rate, right? And that's really great, but it only tells you the hazard rate for the cohorts that you're looking at specifically, and it doesn't give you additional covariates that you can include in there. That the cohort membership is the thing that you're looking at for that. But what if you want to know how several different factors contribute in that given time frame? Well, this value here really won't help you with that because, again, it's bound by the definitions of the cohorts. And again, just to remind everybody, I harped on this a little bit last time, but survival in this context does not mean mortality or life and death. It means time to event or time to outcome, right? At X number of days, Y% of the cohort have experienced the outcome. Pretty straightforward. You can see that all of these is survival probability at the end of the time window. Doesn't mean, I once had a group of students who were like, why do so many of our type 2 diabetes patients keep dying in this study? They're like, that seems really high. And I was like, well, that's because this time to event is telling you when their outcome occurs, not when mortality occurs. Again, like I mentioned in the last session, unless mortality is your outcome. Okay. So to use the Cox Proportional Hazards tool, you're going to have to go through a little bit of a process to figure this out. The first is to define a pair of cohorts that have a distinct difference. That is, one got a medication, the other didn't. One is pediatric, the other is adult. One is diagnosed with a condition, the other is not. So you need a real clear defining factor that basically causes a non-overlap between your two groups, between the two cohorts you're looking at. That's really important to have a non-overlapping pair of groups for this analysis to work properly. Part two, after you've differentiated your cohorts, is to identify your covariates and predictor factors, either from your own knowledge or a physician's knowledge or using existing research or AI. So you need to figure out what your potential covariates are. And part of the reason, and we'll talk about this maybe a little more in a moment, is if you throw in a bunch of irrelevant factors, it can pull allocations of variance from factor. It can make other parts of your model less precise. That's not exactly the mathematical way behind to describe what's happening, but basically it can happen. So every time you rerun, you take components or covariates out of your model, it reallocates the variance to all of the other factors to look at how much they account for in the analysis. So that's basically how logistic regressions work generally. And this type of regression analysis is not too different. So you want to make sure that you're picking things that make sense, but you can also iterate through this and take out things as you go, as you realize they don't make much of an impact and that kind of thing. Then you're going to want to identify the outcome that is mediated by all of these variables, right? You're going to want to look at whether it's, if it's dementia or Alzheimer's disease, or if you're looking at preeclampsia, that's your outcome. And all of these covariates should be contributing to that outcome or in some way. So just as an example, this is how I set up these cohorts. I did not create a cohort map for this yet because this study is very, formative. But basically, we had a control cohort that's not high risk, right? They could be any age. They had an encounter for a full-term uncomplicated delivery or delivery generally. They did have supervision for high-risk pregnancy. This is the control cohort here, the experimental cohort here, that supervision for high-risk pregnancy, which is highly predictive of having some kind of situation going on. And they cannot have pre-existing hypertension complicating the pregnancy or pre-existing hypertension with preeclampsia. The other cohort is full-term uncomplicated. There's no supervision for high-risk pregnancy. This is the labeling on this is incorrect. This is the high-risk group. So we looked at cohorts, covariates. I used AI and talking to physicians to find out what are all the potential covariates that might be complicating our situation. And we came up with about 35, which we thought was a pretty good place to start. And for us, our outcomes are preeclampsia or eclampsia. You can just see some of these examples here. We've got placenta previa and placental disorders and multiple gestation and race and obesity and other kinds of factors in here that and tobacco use and family history, disability, all sorts of different things, chronic kidney disease that might be driving those negative outcomes. So you can see a little bit about how these might look in TriNetX. You can see they're non-overlapping because otherwise being identical, one has the supervision of high-risk pregnancy and the other does not. Supervision of high-risk pregnancy, 009, is fairly widely used. There's about 2 million people tagged with it. So we figured that was a pretty good proxy for high-risk pregnancies, though there could be others out there that we might want to grab. So really quickly, I'll just show you how this works in TriNetX. Basically, the platform, when you put in your two groups, here's our non-high-risk version and our high-risk version. When you put them in here, it looks like any other cohorts section. You can add them just like you would for any other cohort. Then you're going to choose your covariates and your time frame. So here we're looking back only 3 years for our potential covariates. Some of these things might have occurred further back in time, but for our purposes, we're not necessarily as concerned with that. There could be things in here that are important but not necessarily relevant. You can see all of the different factors we've included in here as well. So even stuff that's rarely used but is really valuable that's in TriNetX, like marital status, married and never married, because that can make a difference. And again, things like chronic kidney disorders, lupus, tobacco use, gestational hypertension, things that would obviously definitely predict future hypertension. So once you've added all of these factors into your analysis, you can add them just the same way you would with using this code picker, just the way you would for anything else in TriNetX. You could add them by ICD-10 code or CPT code or whatever is relevant. And you can also use the include age at index and include sex characteristics. In this case, we did not include sex because we already generally are talking about female individuals or female birthers, though there could be other kinds. This is not really as much a discussion of gender as it is purely of who's pregnant and who's not. And we, in this case, used age at index as a covariate. So you can see when you click the age of index box, it adds age at index into that cohort. So once you've added all of your factors in, you can, just like before, set your look forward period here, same day to 1 year in the future, which is our time frame that we're looking at. And then you can add whatever outcomes you would like. Now, this is one thing to note. in TriNetX is you can only add one set of outcomes per thing. Unlike in your outcomes comparison tool, you can only add one set of outcomes here. If you want to do that, you want to add more or run this study on multiple outcomes, you have to clone this analysis, duplicate it, and adjust it over there. So let me just take you back here. So once you've done that and you run it, it will present you with the screen that looks something like this. So here's what to know about TriNetX and how this works. So when you, unlike in a normal Cox proportional hazards model, basically you get one big pool of people and you look at how each individual covariate interacts with that pool, how much risk it adds or subtracts or doesn't impact in that pool. TriNetX asks you to do the two non-overlapping cohorts because it adds a nice wrinkle to it, which is cohort 1 or 2 membership. So what this tool does is basically say, does being in cohort 1, that is having the single factor or the single series of factors that creates the non-overlapping cohort, how much does that predict? How much does group membership predict the outcome? So in this case, preeclampsia or eclampsia, the being in the high risk or not high risk group predicts that you would have about a 1.13 times likelihood of having that outcome. However, it's not statistically significant, so it's probably not much of an impact. There's really not much going on there in terms of group membership. So high riskness doesn't make as much of a difference. So once TriNetX has shown you those two, binary variables, group 1 or 2, whether that has a statistically significant hazard ratio, it then goes down and starts looking at each part as part of the group. So the younger you are, the less likely you are to experience some of these outcomes, or rather the older, you can think of it for basically age decreases your likelihood of experiencing the outcome. Having type 2 diabetes increases your risk by 1.19 times, which is statistically significant. And you can go down here and see all of the different rates at which this impacts it. So having a post-term pregnancy makes you less likely to have preeclampsia following delivery. And I'm just trying to find some big ones here. Yeah, so having gestational hypertension makes you 3.838 times, 3.84 times as likely to do that, which is probably a pretty monster effect size, which is not that surprising because having, hypertension beforehand is probably going to lead to, having gestational hypertension is probably going to lead to post-pregnancy hypertension as well. So not super surprising. So just to review that again, you're going to look for your hazard ratio. This is how much being or having the associated characteristics or being in one of these groups increases your odds of having that outcome. And this is how statistically significant each one is. And then you also get your 95% confidence interval over here if you want to use that to report. So when I ran this a couple of times, we found some really interesting stuff, which is once we got the impact or the factors figured out in the Cox proportional hazards model, we found that these were the ones that had we used sort of an artificial cut point of 1.2 times more likelihood of this. So now that we've run, in some ways running these, the Cox proportional hazards model is relatively straightforward. It gives you a pretty straightforward set of numbers and a pretty straightforward set of information, or set of values. But what do we do with that, right? So now that we know that abnormal chromosomal and genetic findings on antenatal screening of the mother, that confers a 25% additional risk to the person's outcomes of having preeclampsia or eclampsia postpartum. What do we do with all that information? You can see here actually again, so gestational pregnancy-induced diabetes was very high, and cesarean without indication also almost doubles your risk, or is associated with, let's say, with a doubled risk. And having hypertension going in, almost twice the risk as well. All these things fairly make sense to everybody. Now, here's something we could do, though, with that information. It was possible to go back and essentially create a model that tests these characteristics. How predictive are these characteristics of outcomes? Now, we can't tell in a predictive, like a prospective study way, but what we want to know is essentially how sensitive is our model to some of those outcomes. And you can see I went through multiple iterations of these, looking at different levels of factors. So I created cohorts back in the main study where you can set, here's our patients who are, for example, we were looking at Hispanic, Black, or white patients who had an encounter for delivery and were being supervised for a high-risk pregnancy. So we know that these are high-risk individuals. And using a tool that I told you about back in session 1 or 2, I think it's session 2, you can set how many unique instances of a term a person has. So what this allows us to do is say, how many of these, 15 factors in here will we require a person to have before their index event categorization is assigned, right? Before they're entered into the study. So in this case, I went through several versions where I have, you can see over here, I created one with 3 or more risk factors, 5 or more risk factors, and in this case, 7 or more risk factors. And that allows us to then see, okay, out of all of these here, how much increased risk do you start to get as you go? And you can see over here in our outcomes version, when I ran this using propensity score matching to help control for a number of the variables like age and things like that we would anticipate seeing, you actually start to see that people with more risk factors, go figure, right, wind up having much higher rates of postpartum preeclampsia than the non-high-risk groups without any factors. So that wound up being, especially when you propensity score match, it wound up being quite a significant difference between the two. And we wound up, when you map it, you wind up finding that when you use these factors as predictive, as predictors of outcomes, any factors wind up increasing rates of postpartum preeclampsia by 1.7 times. 1 to 2 factors is at that lower end at 1.7 times, but 3 or more factors is 2.8 times. 5 or more factors is 4.25 times, and 7 or more factors is up to like 8 and 9 times more. So I ran this both with and without propensity score matching just to see if there were any differences. And while they're slightly different in their final outcomes, they both show the exact same upward trajectory. So these factors, when you combine them, are predictive. The more of them you have in there. Now, we could go back and try to weight the factors individually and say, well, if they have 3 of these and 5 of these, how much does that impact their outcome? Are there factors that are more definitive than other factors? But we can also use our Cox proportional hazards value to help guide those selections as well. I would strongly recommend, before trying to use this in a study, reading the TriNetX help site information on the Cox proportional hazards model. They actually do a very good job. You have to read it carefully because it's quite complex, but they do a very good job of taking you through the logic of why their tool and how their tool works to provide these kinds of metrics on your various components that you're looking for. So I think this is a really useful tool. I've had students do really cool stuff with it, like look at, rather than running specific individual outcomes analyses, looking at, for example, PTSD and Alzheimer's by race, they were able to do that in one Cox proportional hazards model, which is really useful to tell not just whether there's a difference between the two, but how much of a difference these things make in a particular time frame. These covariates that you're looking for, like race, have on outcomes like Alzheimer's for PTSD, patients with PTSD. So that's a little bit about the Cox proportional hazards model so far. That's the main things I'd like that would be great for you all to know using this tool. I also want to contextualize it within a specific kind of study that one might conceivably do. In fact, I was just meeting with some folks today who are looking at postpartum preeclampsia and eclampsia and looking at this, and they're finding similarly that there's just not a lot of guidance out there in the research, even from ACOG, about how to spot it in advance. So maybe a study like this someday will help shine some light on those outcomes and make it easier to spot for people in advance. Before we go on, do I have any questions or thoughts about the Cox proportional hazards model today that might be of use? And of course, feel free to leave any questions in the chat, and I am happy to answer those as we go as well. Okay. Well, feel free. I'll answer some in just a moment as we get some questions in. Let's take a look at treatment metrics. This is another really valuable tool that I think answers a lot of questions that both patients and journal reviewers might ask you about studies that you're working on, particularly related to specific kinds of procedures and medications. So the treatment pathways tool is right in the middle of the TriNetX tool belt, if you look at it there. But it's kind of a little bit slept on. People don't use it as much in the published research as I think it warrants, because it answers a lot, as I said, of questions that people will ask. So let me tell you a little bit about how to use it. Once you click on it, you're going to input a cohort that you're interested in finding out about how long they've been on particular treatments for. It's a fairly simple question, right? But it is important because, for example, on the example that I've been using so far for our course with Alzheimer's and statins, there are going to be a lot of questions from them about how long people have been on the statins for on average. Do they change lines? Or some people, for example, if we are looking at lipophilic versus hydrophilic statins, are we seeing a lot of people changing lines between those? And this tool really helps with assessing that. So as you load your cohort in here, you can go and, much like all of the other tools in TriNetX that have stars next to them, you can go in and load your cohort and look at all of the procedures, medications, and basically procedures and medications that are visible to the platform. And you can star those, and you can choose them, and that'll add them to your saved treatments tool over on the side, so you can access them later on when you need to add them all to your analysis. It's very similar to starring outcomes in the compare outcomes function. And when you do that, you can see over here on the right, it shows up as this little box under Save Treatments, and you can add them into different buckets if you want, or you can just have them all compared one against each other. So in this case, I've got two buckets. I've got a hydrophilic and a lipophilic set of statins that I can create. And now what that's going to do is group all of these medications together into one group that I can analyze in terms of time and use. So I'm going to switch over to the live site for a second, because some of this is actually kind of interactive, which is neat. And one of the things that you find with this, sorry, 1 second as I log into my account. Oh. Here at UCR, we have a very aggressive two-factor authentication system. So sometimes you can find yourself logging all the way back in. Okay, so what you'll find when you're looking at, this is my statins people with a 10-year look back, so to include people as far back as 2015. switch to a different, here we go. Here's my 10-year look back. Again, you can look actually at your characteristics as well if you want to save any particular characteristics for your study that you want to include. And again, as I pointed out, you can include specific treatments. I'm actually going to skip the lines of treatment today in the interest of time. But you can see this actually tells you what percentage of people started on a treatment and how many of them switched treatments over time. And the sunburst diagram actually is very useful over here on the time on treatment function. Okay, so we're going to jump to this section that says time on treatment over here in the left column. It's one of the most useful analyses in here. So what this does is essentially the sunburst diagram, kind of an interactive diagram, and it allows you to look at specific chains of events in the person's record. So in this case, we have everybody who started on one of our lipophilic statins and then switched over to a hydrophilic statin and then switched back to lipophilic statin. You can see that's like 0.844% of people, right? So a tiny fraction of all people, with about 4% of people switching from the lipophilic to hydrophilic later on, usually because rosuvastatin is extremely powerful. And, for people for whom, let's say, atorvastatin and Lipitor are not working properly, you can switch over to one of the hydrophilic statins, and that'll sometimes do the trick. It's also a little easier on some other outcomes as well. You can see over here, this defines people who started on hydrophilic ones and then switched over to lipophilic, and then finally. So there's a little diagram up at the top here that I can't now. So here we go. Actually, I can click on it like that. You can see this tells you that order and allows you to see it. Now, when you do that, I'm gonna switch over here and look at people who had all the lipophilic statins. You can see down here, it'll tell you your time to selected treatment here. So this is about how long between the time that people entered the study and the time they were first prescribed that medication, about how many months or years it goes on like that before they get that treatment. So that can be really useful depending on the kind of study you're working on. But the time on treatment can be very valuable as well. So I'm imagining that when we are finishing our study on statins and Alzheimer's, the reviewers are probably going to ask us, well, how long were people on medications for? And we can say roughly 3 years plus or minus 3 years. So as little as 1 year post entry to the system, meaning they'd been on it for 2 years at that point. And up to as long as 3 years into the future on average, with one standard deviation out. With the longest one in here is about 10 years or so in the records. That's the maximum time frame. And you can see it gives you some information about how frequently people switch medications as well, how many people die in the course of the study. So about 25,000 people ended out, and how many people's records actually just ended. So out of the 1 million people, about half of the records don't have any additional information after 60 days out. And that is where we set our cut point. You can set your cut point further in or further out to include or exclude people, but that can really help to reduce confounders on that. And similarly, here's a graph of all of those information in terms of time. So this is the retention time. So survival probability, familiar again to us, our time to event chart here, and our time going over here. So this is like a Kaplan-Meier analysis for that, or Kaplan-Meier curve for that. And again, to change, let's say we wanted to catch the other side of that, right? And look at lipophilic outcomes. Well, that is, you just click on that sunburst diagram button, and it'll show you what's going on with the lipophilic people. So we tend to be, in this case, on for 862 days, plus or minus 886 days. So you can see here as well, some people drop out of the record over time, and otherwise people in the hydrophilic tend to stay on it. I guess as they get older, maybe they're taken off of it if they're out of the woods or something like that. So that is, let me just review really quickly, see if there's anything important. So this is the sunburst diagram that you might use to help guide that. looking at your time to treatment, if that's relevant to the study that you want to present, as well as the time on treatment, which I think is going to be relevant for a lot of people who are doing anything involving medications. Time to treatment can be very valuable for surgeries as well. So this information is really useful. So tonight is really short, and I planned it that way. So next time we're going to talk about actually turning your study into a piece of scholarship that we can look at. And presenting some tools on making posters and AI tools that you can use to help digest down some of your findings and turn them into meaningful analyses. And also to help take a little bit of the burden off the writing as well. Some of these write-ups can have very elaborate tables that manually developing can be challenging. And also maybe to talk to you a little bit about how we've used AI technologies, not just to make the writing sections easier, but also to develop code that can help us produce more interesting and useful analyses later. So that's going to be coming up next week. That's pretty much it for tonight. So I want to thank everybody for joining. I'm going to stop the recording, and for those who are available, I'm happy to share some thoughts. So thank you very much.